Thanks for the nice introduction, Kath. So you sort of know who this guy is, right? Kathy's father, and he practiced medicine for 40 years, and he's emeritus, whatever. But who am I? I'm some poor fool that was wandering the streets of Mount Auburn, and Alan and Kathy dragged me in here and said, you have to tell a story. Now, I don't sing and I don't dance, but I usually have a pretty good nose for a story, and I'm really aging because I forgot my prop with the nose, so I apologize for that. So I assume you want me to talk about this story, the medical home. Well, if you came in here with a concept of the medical home that was a 2 or 3 room office with a parents, a child or children, maybe a nurse, receptionist, and a doctor, that is not the medical home. So those are your old fantasies that I grew up with and I lived through for 40 years. And all the things that you'll hear about the medical home today, we were doing way back in the old days of horse and buggy, except we called it a doctor's office. And now we've gone from that little home to corporate medicine. And what you're going to see today, so this is the current definition of a medical home. It's defined as a concept in which physicians and families develop a partnership, a mutual responsibility and trust that provides medical care which is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. And if you count, those are 7 components. We'll get back to this eventually. So things you need to know as you're reading, because I know you're going to read a whole lot about this the rest of your life, is it's commonly referred to as this, and this. And they all mean the same thing. This is the medical home, this is medical homes, this is what you call the patient-centered medical home, and which I will tell you according to the CMS. You all know who CMS is? That's the Center for Medicaid and Medicare Services. It's under the umbrella of HHS, right? Home and Health Services. Division of the federal government. This is now known as primary care medical home officially according to the CMS. No longer patient-centered as of a month ago. Okay? Just so you know when you're reading what these all mean. So, I think before we get into this, we probably need to give you some history of how we got from there. And I'll give you the short version in case you have to leave fast, right? Well, maybe you ought to know why should you learn this anyway? Well, this is where you're going to live both professionally and personally for the rest of your life. Understand that. The medical home is the provider side of the healthcare changes. Is the health maintenance organizations where the insurance side, this is the provider side. All the insurance companies are looking at it, at least 90 that I know of today. Big companies are looking at it like IBM and Procter & Gamble and GE. And once the practitioners move from that little 3-room office over to the corporate game, they'll never go back. And fee-for-service will be gone. This will be the vehicle that determines the quality of care in the future. And it will be dependent upon your performance in the medical home. Not mine, my day's over. It will be your performance. And that's why you're at the Christ College of Nursing, because you're going to be well trained. Okay? Now, the short version is real simple. It's a place that evolved into a partnership over time. So that's all you need to know. You can go home today and you got it all down, right? A place, partnership, it's done. The place was a single source of all medical information for the patient's care, basically driven for children with special health care needs. And that's something to remember. The partnership is this great monster. So let's go back in time, and you need to know that it was first documented statement of the medical home was in 1967. It was in the American Academy of Pediatrics. It said there were basically 3 steps to it, and the 3 steps had to do with training medical students and getting the doctors convinced that it's a good concept, and then educating the parents that it was important to do. It had some barriers, though. They had to train the doctors to understand the concept, both the doctors in training and the doctors that were already in practice. And then you had all these problems with communication and care coordination for the services in health family support, such as special ed, physical therapy, occupational therapy, social workers. You had to make sure they were going to communicate. Now remember, this is before your fancy cell phones and your smartphones and your computers. This was done on pencil and paper, and telephones that were hooked to the wall with wires. Okay? But that was a barrier. And then reimbursement for the periodic well-patient supervision care did not exist. So what incentive did the doctors have or the specialists have to even get involved in the game? There was no monetary, it was just more work, less pay. So those were the barriers in '67. And remember that it is about children with special health care needs. This was not about your regular run-of-the-mill well person. And adults had nothing to do with it. It was about children. So we had a little thing called the Vietnam War that was going on at that time. So nothing was really done until the 1970s. And then in 1974, COP, that's the Committee on Pediatric Practice of the American Academy of Pediatrics, came up with a statement about the medical home. And they basically said, we want to make sure all the medical records are in the same place, and that it had to do with continuity of care. That was it. They couldn't get it passed by the Board of Directors of the American Academy of Pediatrics because they also wanted to change the concept of terms like your physician, your general practitioner, your pediatrician, your family doctor, to the medical home. And basically they were going to use that on forms, like when you have your forms at school and they ask you who's your doctor, it was going to say, where's your medical home? The Board of Directors said, that's not the way it's going to be, you're going to rewrite this. It took them another 6 years, way back, not until 1979, that they came up with any statement, and basically it said, we want some place of continuity of care and the records in the same place for children with special health care needs. And that was their statement in 1979. Well, in 1978, we had a president by the name of Jimmy Carter, and he came up with the concept because he was trying to get everybody access to medical care, and they developed a thing called the HMO. You all know what HMOs are. Those are health maintenance organizations. They were federally subsidized for 10 years. And so the concept there was everybody was going to have a chance to get access to health care. Part of that HMO was they requested that states and regions have child health plans. So a plan of action, as it were. I have a few things on here. The state of North Carolina went through at least 8 different legislative bills in trying to get their health care plan done, none of which passed, basically because the legislature and the governor said, you're taking away parental responsibility and you're giving it to the doctors. So they didn't pass. But along the road, they defined the 7 components that you saw in the definition. So that was their key, but nothing passed. Hawaii, on the other hand, got something through the legislature, but it took them until 1986. They went through things like, and they very slowly went through things like protection against child abuse and neglect, and then emergency room care, and then education, and something in the community. So they had something ongoing, and they did try to do it for all children, not just children with special health care needs, but interestingly enough, when the law passed, it was children with special health care needs again. And then Cincinnati was doing the same thing. I happened to be on the committee, there were 3 of us, that did the child health care plan for Cincinnati, way back in '79. We had an advantage. We were way ahead of the curve because at that time, all things pediatric went to Cincinnati Children's Hospital. Good Samaritan Hospital had a pediatric program of residency in an 80-bed ward, which was closed, so everything went to children's. So we had all the ancillary services available to us. Communication was pretty much the same because the charts were the same, and consulting letters went back to the doctor's offices, so we had it, we at least had the place. And we worked on such things as what is health? How do you define health? Try that. That's an exercise for you to do over the weekend, define health. And then how do you measure it? And how do you measure outcomes? And we didn't have computers in those days. So that's sort of where we were in '79. So Cincinnati was a little ahead of the curve. By '86, Hawaii had their law, and they got a real nice bonus from maternal and child health care of a grant. And the grant was to train the doctors to know and get into medical homes. So they had the money. By 1989, there was a big conference in Hawaii, sponsored by the American Academy of Pediatrics, to train all of the other states in the union, so that monies then went to all of the states to train doctors to know about the medical home. Another thing happened though. The HMO is gone. The federal subsidies go away after the 10 years. 98% of health maintenance organizations folded. They were all in the red. They were only showing good progress because they were federally funded. Hence, there was no vehicle for the medical home anymore because it wasn't being funded anymore. Money was available for training, but what happened in '89 is in maternal and child health from '86, they ran out of money. They lost their grant money. So they took the money and they made a deal with the American Academy of Pediatrics to do some medical home training. And we'll get to that in a second because it doesn't take place until 1999. By 1992, we have a new president. We have President William Jefferson Clinton. And we're going to have Clinton Care. Except the insurance companies put up a big lobby and they said, no, we do not want national health care. We've been doing this longer. We know how to do the insurance side. And if you do it, you're going to have to start a whole new bureaucracy, and it's going to fail because you won't be able to handle the cost. Let us manage the care. So we then had managed care organizations. And that's what you probably all grew up with, were managed care organizations. So that's how those came about. The insurance companies lobbied. We didn't get Clinton Care. And then by 1993, the American Academy of Pediatrics came out with their first so-called policy statement, which basically said the place, again. And they did develop a division called Community Pediatrics Divisions of the American Academy of Pediatrics, and that's important, as you'll see going forward. And they started the CATCH program, and the CATCH program basically was a community program for health care within a certain community. It's community access to child health, which promotes the medical home. Again, all of this is for children with special health care needs. Think diabetes, congenital heart disease, Down syndrome, nowadays autism, okay? So there we are in '93. By 1999, the grant money's run out from the Maternal and Child Health Care Bureau, and they go to the Academy and they cut a deal and they give the Academy dollars for 5 years to develop the medical home. And that was through the Community Pediatric Division. If we didn't have the Pediatric Division, there wouldn't have been a medical home program. And that is now known as the National Center of Medical Initiatives for Children, and it's now, and then it changed names to the National Center for Medical Home Implementation, or NCMHI, and that's where it is today. And that's how the medical homes get funded, through the Affordable Care Act and through places like CMS. But it's still for children of special health care needs. So we get to 2000, and the definition you just saw comes out as the medical home, 2002. There's 7 components to it. You saw them all. But they added a little thing here. They added 37 activities to make up those 7 components. And I will tell you, as you're sitting here, you will need to know all 37 by the time you are nurses. And we're going to show you those, so you don't get too frightened with this. You know, how do you eat an elephant one bite at a time? But that was new. And that sort of floundered around. But in the meantime, we get a new president in 2008. We had that little war in between there too, Iraq, and the Affordable Care Act gets passed by Congress because it was a Democratically controlled Congress at the time. And by 2010, this person makes a promise to the state. They're going to fund coordinated care for kids with special health care needs at 100% access. So every child with special health care need would have access to a medical home. And it's not that 3-room office either. Interestingly enough, to date, only 15 states have been funding, and there's no plan for them to be funded next year. So the promise was never fulfilled. And that brings us to 2012. We have a new alphabet, and it's the ACO. That's the Accountable Care Organization. Now, you all know, you see, how long have you been at the Christ Hospital School or College of Nursing? A couple of weeks, 10 days, whatever. Huh? 3 months? Okay, you do know that the Christ Hospital is an ACO. They told you that right out of the chute, right? An Accountable Care Organization. So is the Mercy Partnership Health System. So is Children's Hospital. It's the Affordable Care, or the Accountable Care Organizations that administer and monitor the medical homes. And that's going to get us back to those 37 activities. So that's what they do. And then by 2013, just a year ago, we had this problem with the electronic health records. And those had to have meaningful use. It's not just a matter of you come in, you pay your bill, and it gets sent to the insurance company, and it gets coded somehow so the doctor gets paid. It had to show that the electronic medical record had a meaningful use, such as, can you monitor and tell me how many diabetics you have in your practice? And do you know what their hemoglobin A1Cs are, and can you bring it up and monitor it, and can you track it? That's what a meaningful electronic health care record is supposed to do. So that was supposed to go into being in 2013. I'm going to give you some information that says it doesn't exist yet. And you were going to use clinical quality measures, CQMs. CQM basically is taking 6 of the 7 pieces of the medical home, those components, everything except accessibility, because an electronic medical record cannot make care accessible, but it can do the other. It can give continuity of care. So that's what was supposed to happen in 2013. By 2014, they said, whoops, can't use all 6, it's too hard. People just can't get this done. We'll decide that you can pick 3 of the 6, you know, it's like a pick 6 if you're going to the theater, and those are the 3 things your office is going to work on to show that you're going to improve quality of care and decrease cost. So that's where it is in 2014. And thing to look forward this coming spring is the TCP, well, I'm going to call it TCPI because I think that's how the newspapers will report. Those are called Transforming Clinical Practice Initiatives. They come from the CMS, and they will give medical practices technical assistance and financial support to deliver efficient patient-centered care to the cost of $840 million a year of your tax dollars. So that's the history. That's the story. Now, there's some barriers with all that 45 years of history you just walked through. There's a shortage of manpower. Last date, 2012, the American Medical Association tells us that only 29% of the doctors are primary care doctors, when it should be 70%. That's where you're going to come in, because they've decided that the nurses are going to fill the gap. But I can tell you this much. If we take all of the nursing students in all the nursing schools in the United States, starting in 2005 through 2025, and they all became nurse practitioners, that's when you'll catch up for what you needed in 2005. Population is going to grow. People are going to age. And oh, by the way, in the meantime, you don't have any nurses who do anything else. So that's not going to really answer the question, but it is a barrier. Then there's limited time. Officers are already working 12, 14, 16, 18-hour days. Where is the time to do all this paperwork and do this monitoring? Where's that time going to come from? And the tip is, it's not going to be the doctors. It's going to fall on the shoulders of the nurses, because that's how you practice medicine. And we'll show you some of your responsibilities you're going to have going forward and opportunities. So understand, this is a big thing. Okay, there is a requirement for health information infrastructure. It's a barrier. The medical home requires modern health information systems. They're costly. Roughly, in a small practice, is $1 million, and another $50,000 per doctor, and probably another $50,000 per doctor per year to maintain your system. And today, only 40% of large practices currently use electronic health records, as much as you hear about it on TV, and the smaller practices hardly at all. And the systems don't always interface. There are 2 recent studies that were reported October the 1st of this year. Fewer than half of the nation's hospitals can transmit a patient care document, and I'll give you an example of that, and only 14% of doctors can exchange patient data outside the hospital into other providers. Now, there's supposed to be that big communication thing that we talked about earlier, barriers. And the electronic medical record was supposed to solve that. And to date, it has not. And then, of course, by 2015, we're going to have to spend another $840 million so that the doctors can maybe get on board. There are criteria for the medical homes. And now the 37 activities, according to the American Academy of Family Practice, are up to 42 activities. And they did a demo study for 2 years to see how long it would take a practice to be able to come up and have those activities available to the patient. And in 2 years, none of them could get it done. So we have a time problem. And based on that, the National Committee on Quality Assurance, the NCQA, went to a 3-tier program. We'll break up the 42 things into 3 groups, roughly 14 or so. And they'll give you 2 years to do each tier, so you would qualify separately. There's a tier 1, tier 2, tier 3, so you can qualify on an ongoing basis and not be in non-compliance with the Affordable Care Act. Because if you're in non-compliance with the Affordable Care Act today, as a practitioner or a provider, you don't get paid. So that's the carrot that drives you. You want to get paid for your services. So if you use the NCQA's idea, it will take anywhere from 6 to 8 years to have qualified medical homes starting today. Then there's resistance from the providers and the consumers, of course. The physicians have lost their autonomy. They have to share care of the patient with care managers, pharmacies, insurance companies, and they have to let all that information go. Of course, there's the HIPAA laws and Privacy Acts that says, well, you can't share it with everybody because you need permission from the patient, and that becomes another barrier. What do we do with that? And then the specialists have no incentive at all to communicate with a medical home unless they're part of a big group and inside that structure, because then they're part of it and they just get paid as they normally would. But there's no incentive if you send somebody over to Children's today for the cardiologist to get back to your medical home with a lot of information. They're busy seeing patients. And then, of course, the consumers. They're upset because you're restricting their freedom to see their specialist. And I can tell you that starting January 1st, United Healthcare in their new contract will require that you have to see your primary care doctor before you can see your specialist. So if you break your ankle playing out running today, if you're jogger or bicycling or playing racquetball or whatever, and you know you need to go see the orthopedist, you still got to go see your primary care doctor and have them bless you and say, yes, you can go see. Now you pay a copay for that, and then when you go to see the subspecialist, you get the copay again, but he says, I want to see you back in 6 weeks. Now you're going to have to go back and see your primary care doctor and play the game. This is what we did with the HMOs way back in the 80s. So we're just reinventing the wheel. It's a way for the insurance companies to do what they call make money on the run, because they're holding the money before they pay it out. So that's a problem. And then you may have heard of a thing called death panels. They don't exist yet, but according to the Affordable Care Act, the President of the United States will name 9 people, non-physicians by the way, there are no physicians on the panels, and there may not even be a nurse. There may be what they'll call a health provider, which could be a social worker in essence. And they will determine whether people at certain ages with certain conditions can get the care they need according to the existing guidelines. And one of the cutoff ages happens to be 75 for many of the care. So the people are worried, and then of course if you don't get your care, you probably, you have your leukemia from Agent Orange and you can't get your chemotherapy, you're probably going to die, and that's why they're called death panels. So you have a rough idea. So the consumer is the resistance. And then reimbursement is still a problem as it was way back in 1967. The insurers do not currently reimburse for enhanced services from the medical home. There's no current billing code for medical home services, and the projected capitation fees are inadequate to support the patient-centered medical home. So, does a medical home work? Well, we've got 5 good studies that have been done, and I won't go through each one of these. But basically, the North Carolina study, they thought they were in good stead. It was roughly 14 community health works, Medicaid patients, people with chronic disease, special health care needs, and they reported that they would save $60 million in 2003, and it would increase each year up to $161 million by 2006. The reports look wonderful. Everybody was agaga. Independent audit found out the state lost $400 million per year during their study. Because again, it was a subsidized program and they forgot to add in that money that the state was giving them. So maybe it didn't work. The Geyser Health System is in Pennsylvania. They own everything. They own hospitals and clinics and doctors and nurses and everything else. And they showed a decrease of hospitalization by 20% and cost by 7%. The problem with the hospitalization decrease is they dollars shifted. They took a section of their hospitals and said, oh, that's outpatient. That's not hospital. And it was about 20% of the buildings they had. So it was a skewed number. But they at least showed some improvement. The Medicare Coordinated Care Demo Project was interesting because it preceded the Affordable Care Act. And it was one of the things that Congress used in order to drive the Affordable Care Act. But well, we got this great study. And it's 15 major communities, major centers in the United States. It was followed for 3 years. We were supposed to be able to show that this is the way to go. Their healthcare costs increased by 11% per year. So it didn't decrease costs, and they were not able to show increased quality of care either. It was stagnant. It didn't get worse, but it didn't get any better. And then the urban health plan in the Bronx is interesting. It's relatively new. It's in a community which houses an activity center for the community. There's 531 providers. They only see 300 to 500 encounters a year per doctor. I used to see 8,000 to 10,000 encounters a year in general practice, as did all my partners. So to give you a rough idea, it's not a very big, activity group. They're open 24/7. That's good. You're in the neighborhood because you don't have to worry about how far you don't have to drive a car or take a bike or anything. You just walk across the street and get to it. They're trying to decrease ER visits and they're trying to decrease unnecessary hospitalizations. And again, they're funded by state and federal funds. They haven't been able to show that they've saved any money yet, and they don't have any performance. The best they can tell you is that some of their studies so far have showed improved morale among the staff. So you made things better. They feel better about it. If you want to know about that, this is one you can write down. It's a thing called Talking Health. It's a TV show. You can see it online. It was episode August 1st, 2012. And it's a whole story of the Bronx. So they probably have some good things, except they don't have enough data yet. And then the latest one is the state of Iowa. They legislated in 2008 and 2011. They launched it in 2012. They have 2 programs, one for people with chronic health needs, mostly adults, some children, and basically hypertension, heart disease, diabetes, substance abuse. And then the other program is for people with mental health problems, both children and adults. They use a capitated basis. So far they haven't been able to fund it well. They haven't been able to pay the providers well, so any savings they're showing is because they're not paying the doctors. And interestingly enough, they're going to monitor this to see if they're successful by the decrease in the number of school absences. And that's all they're going to monitor. So I don't know if that tells us anything, since the adults aren't going to school. Or maybe they are going to nursing school, I don't know. So what about the Affordable Care Act and medical home? Okay, it's one indicator of quality. The Affordable Care Act is going to encourage the medical home. It's going to charge, the law itself charges CMS to reform payment and practices through the use of the medical home. In other words, if you are able to show that you've improved quality and decreased costs, you get paid more. It's like a bonus. Of course, if you don't do this, you'll get paid less. So that's supposed to be an incentive. Sometimes, as you all know in medicine, you can't really make it a whole lot better. Stagnant is stagnant. It's going to emphasize the medical home model for low-income populations. It will fund training and CME to promote medical home strategies to the cost of $11 billion a year. Interesting enough, in this year, HHS was supposed to do a survey on the use of the medical home in Medicaid. Never happened. Of course, we changed secretaries along the way, and I guess that got lost in the shuffle. And by 2017, we'll have a new president by then. There'll be an independent evaluation on the effect of the medical home in reducing hospital admissions, ER visits, and admissions to skilled nursing facilities is supposed to take place. Well, we don't know because they didn't do this first. Maybe we'll get this by then. We'll see. And it also provides another $11 billion for patient-centered medical homes in underserved communities called Federally Qualified Health. The Federally Qualified Health Plan, that's Medicaid and Medicare. They just changed the name so it sounded really nice. So, we're back to our definition. All right? Now, if I sent this to you today as a tweet or what do you got? You text, don't you? You all text and do that. And I said, I want you to go over this and give me a program to the class on Monday morning. What would be your text back to me? 1 or 2 words. Anybody got any ideas? I hate to put the pressure on you all. I'll give you a couple. First one is utopia. There it is. You'll never see it any better. But the most likely one that I would probably hear back from most of you is and you all know what that means, right? You don't have to tell me. I think you probably all know it, right? But just so you remember, wow, that's fantastic. Okay? So, that's sort of what I think you would do. This is so awesome. It's unbelievable. Now remember, these are only the 7 components. There's those 42 activities. So we're going to look at the 42 activities. Well, first of all, Remember I told you it was just the doctor and maybe a nurse receptionist and a mom and dad and the kids, right? Here we are today. There's 15 different entities on that, and I've seen it as high as 20. And that's what's supposed to entail a medical home. The problem is it's all scattered all over the community, and how do you have it communicate? The electronic health record was supposed to solve all this. Hasn't happened. But that's what the medical home entails. So it's accessible, right? It's provided in the child's community, all insurance is accepted, the practice is accessible by public transportation. Ha! If you go out to Harrison, Ohio, where I did some practice at the end of my career, there is no public transportation, and I understand the trolley car is not going to Harrison. So, families can speak, of all things, a family can speak directly to their doctor. That never happened in our office, did it? Okay, and the practice is physically accessible. Okay, so these are part, that's 1, 2, 3, 6 of the activities. Now understand, in these activities that are related to the components, the practice not only has to show that they have this, but they have to also show that it decreases cost and increases quality of care, and that you can monitor it and show it. That's what the medical home is all about. Now the one thing that's missing here that I thought was interesting, basically, it doesn't say 24/7. And remember I showed you those 5 other plans that have gone as sort of pilot studies, and only one of those 5 was 24/7. So conceivably you could have your medical home clinic, it could be right here maybe at the Christ Hospital, but it closes at 4 o'clock in the afternoon, and after that you're going to go to the emergency room, which the medical home is supposed to prevent. So I thought that was one they should have added. It's continuous. You see the same pediatric professionals, you have assistance with transitions, and the doctor takes an active role during hospitalizations and discharges. I don't think so. Most of the community pediatricians today don't see their patients inpatient in the hospital. They're seen by hospitalists. So how can we do this? Active role. Some of the pediatricians don't make nursery rounds and see the newborns. They leave that to the neonatologist. So are they part of the medical home? They're not paid by the medical home. So I think there's some problem there. It's comprehensive. The physician is going to facilitate the management aspects. There's ambulatory and inpatient care for ongoing acute illnesses is insured. Preventative care is provided, and the physician is an advocate for the child. Well, these are all things doctors do, so this might be an easy one for your medical home to say, yeah, we do this. Also, the child's medical and educational developmental cycle. Wow. You know, the doctor's not going to do that. The nurse is. They're going to say, Nurse Susie, contact the school and let them know about Johnny's attention deficit disorder. And, you know, call over to the social work and see if you can have somebody make a home visit. And then you're going to report back to the doctor and say, I did that, right? Information is made available about private insurance and public resources. I've been in and out of a doctor's office for the last 6 months. And I can tell you that when you do this, you know what they sell you? You know what the girl at the register says? Call your insurance company. And that's how the insurance company becomes part of the medical home. The receptionist doesn't know the answer to your question. In fact, they don't even know most of the time whether your insurance, because Blue Cross Blue Shield has, you know, 80 different choices. They don't, and you're working for company A and they got choice 3, and so the office doesn't really know. There are in our practice that I retired from, we did have an electronic system that would tell us the minute you came in the door, the minute you gave us your insurance card, whether or not you were part of the practice and whether or not we were going to get paid. That system only cost $500,000. Not every office is going to be able to afford that. But most of the time it's going to be call your insurance company. And extra time is scheduled for, well, that's what we did in our office. We schedule patients. It's family-centered. Medical home physicians known to the child and family. I would hope so, at least after the first visit, that you know who your doctor is. There's mutual responsibility and trust exists between the patient, the family, and the physician, and the family is recognized as a principal caregiver and center of strength and support. There's clear, unbiased, and complete options are shared on an ongoing basis. The families share responsibility in decision-making. Family is recognized as an expert in child's care. Which begs the question, what kind of expertise does the doctor or the nurse have? Since the family is already recognized as the expert. And it begs the next question, it's called liability. I happen to edit a book on medical liability for pediatricians. This becomes a liability question. If the family is making the decisions, and if they are the expert, and there's a bad outcome, how come you're allowed to sue the doctor and or the nurse and or the hospital? So it's going to be some interesting legal changes in our system. It's coordinated, it's a plan of all things, a plan of care. That's been going on since Hippocrates, folks. When you say you have strep throat and I'm going to give you penicillin, that's a plan of care. So, and it's shared with the family. So you're telling the family, you know, Junior needs a shot of penicillin. Okay, so that's going to be an easy one for you to both monitor and stay that you have in your practice. A record is generated. That gets back to the original plan was it was a place. And the medical home shares the information with consultants. Well, that was what this is what the electronic healthcare record was supposed to do. And then families are linked to support groups. It's also coordinated because physician reviews and interprets the specialist recommendations for the child. Not always. Remember, there's no incentive for the specialist to necessarily get back to you in a timely fashion. They'd be just as easy to say, come back and see me in a week or two. And then I'll send a letter next month to your primary care doctor. So that wouldn't necessarily happen. And then a plan of care is coordinated with both the educational and other community organizations. This is something the nurse is going to end up doing. Because if you have a child that needs an individual educational plan because they have a learning disorder, the school it has to be signed off by the physician. There's several pages to that. But the nurse is the one that ends up contacting either the principal or the teacher and say, yes, we have a plan that's signed. This is what we expect you to do. And we've had situations in this community where we've done this through the Center for CCDD, Center for Developmental Disorders at Children's Hospital, where we've had the real super experts on education go as a team to schools for a child. And the school says, that's fine and wonderful, but I don't have the resources, the special ed teacher, to do that. And so it doesn't get done, and the patient ends up on the doctor's doorstep the next morning. And the nurse is the one that has to be the coordinator between the two, because the doctor's got 40 other patients to see with acute illness. So those will be some of the wonderful things you'll be able to do as nurses. If you're not compassionate, you shouldn't be in medicine. It's that simple. Should be culturally effective. You should recognize the family's cultural background, like, you know, I'm from the west side versus the east side. You know, I'm a Reds fan, I'm a Bengals fan. You know, I don't cross Vine Street without a passport. You know, something like that. And the religious rituals and customs. This is interesting. Provide written materials in the family's primary language. How many of you have been on the wards or in a clinic or something that actually had patient care? Any of you yet? Okay, commonly what happens when you go to the hospital and you have your time and then you're going to go home, they hand you a document that is a summary of the care you received and the plan of action, and usually something about your medications and something about maybe your diet and appointments you're supposed to make. Now, if I came to the Christ Hospital and I was from Africa and I happen to speak Swahili, There's 14 different dialects of Swahili, by the way. Do you think that they've got printed material for that summary and whatnot in my Swahili? No. And I can tell you in a private practice, if somebody comes in, and I only speak English, by the way, and they, even if they're Spanish or German, Vietnamese, whatever, and I need an interpreter. Now, they may have a child who's in 2nd or 3rd grade, speaks good English, is being educated in the school, and they speak the language with the parents, and then they're able to tell you the story. But by law, I can't get the history from that child. Okay, it's illegal. I can take it and we use it and we write notes to each other. But if I need an interpreter, interpreters in this community charge $75 an hour, and you must have them for 4 hours, guaranteed time, whether they spend 10 minutes with the patient or 15 or the 4 hours. So you have to pay them $300 for a $60 office visit. Doesn't make sense. So practically what happens in this community? What happens if you have any language problems, you go to Cincinnati Children's Hospital and you go to the PPC clinic, which I worked at off and on for 40 years, because the interpreters are there and they're paid by the hospital. But they don't know all 14 dialects of Swahili either. And the printouts basically are the classical languages. You know, it's English, Spanish, German, French, Italian, some Vietnamese, some Korean, very little Chinese. So that's a major barrier for the medical home. Why they put that in there, I have no idea. Now, you're going to bring some skills to the medical home. You're going to graduate from this great institution, the Christ College of Nursing, and these are the national skills. If you are an RN with a bachelor's degree in the United States of America, the American Nursing Association says, this is you. You know pathophysiology of disease processes. You will know the physician's preferences and philosophies, because when they hire you and they interview you, you're going to discuss that. So you're going to know that. And you're going to get help from the rest of the staff. You're going to know resources, because that's what Christ Hospital taught you how to do, was to find resources. You're going to know about insurance and reimbursement. You're going to be able to go home and tell your parents, your relatives, all about insurance. And they're going to tell you something they read in the paper the other day, and you're going to say, that's poppycock, I know what the real answer is. You're organized. You have a strong nursing background because you went to the Christ College of Nursing. You're going to know about child development and family theory. I think, do you still do your pediatric training through Children's Hospital? Let me tell you, Children's Hospital is the #1 children's hospital in the world. We're better than Hopkins, we're better than Harvard. And we can prove it. We get more federal financing than any other children's hospital in the world. We have more international patients than any hospital in the world. We're also the largest children's medical center in the world. Count your blessings, Cincinnati. Because when you leave this community, if you do, you won't see anything like it. So when you have your time at Children's, use every ounce of it. Be a real sponge, because there's a lot of knowledge over there. You know the culture. You'll have known something about basic research, whether you did some or not, but you at least know about it and you'll know how to interpret it, because you came out of the Christ College of Nursing. And you'll have a BSN. So that's your minimum. Here's some other roles you're going to, here's some skills you're going to have. You're critical thinkers, you're problem solvers, you do multitasking, you know how to communicate, you know interpersonal relationships, and you have that strong nursing. But this is the piece I really love about nurses. This whole thing right here. You're persistent, you're highly organized, you're curious, and you are detail oriented. No policy in any hospital gets past the nurses. They know all the roles, and that's what nurses do. Okay? But there's 2 things that I want you, because you're not going to memorize all this. So I give you 2 words that you need to know, that skills you have to have. And they both start with C. The first is competency, and the second is, senior moment, compassion. If you are competent and have compassion, you will be a great nurse. And I can tell you that going forward, because we just did this over at Children's the other day. The education of healthcare providers, because we have to change the names now, we can't call them doctors and nurses anymore. Healthcare providers is going to be based on your competency. It's not going to be based on what year you are in school. So if you can't show competency in a certain area, you're not going to move to the next level. I can tell you that Children's University of Cincinnati is doing it, Duke is doing it, Vermont is doing it, University of California, San Francisco is doing it, and the University of Texas. So when you see curriculum changes occur, and this will probably occur right after you get out of school, so you're off the hook for the most part, realize that's what's happening. That's what the curriculum changes are going to be, competency. But you're going to have that because you're going to come out of the Christ College of Nursing. Okay, now these are some things you'll be able to do in a medical home. Wow, what an opportunity. You know, wow, that's fantastic, right? You can do case management, team membership, direct patient care, patient education. You can be the HIPAA compliance officer for the whole medical home. Somebody's got to do that. And by and large, and I happened to give the initial lectures on HIPAA way back in the 1990s, the doctors wouldn't pick up the ball. And what they all did is they slid it off to Nurse Susie. But the nurses knew what was going on. Most of you probably are because you want to do this. And you know you're going to do patient education because every asthmatic that comes in, the doctor's going to say, oh, you got this new asthmatic here. I gave him some short-term meds. Nurse Susie come in here. This is Nurse Susie. She's going to teach you how to use your inhaler. And you need to make an appointment and come back in a week and see her and see how you're doing. He doesn't say, or she doesn't say, come back and see me. I want to see you in 3 months and see how your program's. And Nurse Susie's going to show you how to monitor your asthma. That's the patient education piece. You're going to coordinate care with the insurers. You're the one that's going to be having to call and say, you know, why didn't you approve this drug for this chronic illness? Yeah. You're going to be the one on the phone because the doctor doesn't have time to wait on the telephone. You might review evidence-based protocols. More than likely, most nurses know about the guidelines than the doctors do, because that's what nurses do. They have those skills. And you will probably be the one to develop and monitor the patient registries. And that's that one about the diabetics and the hemoglobin A1Cs and how you're going to monitor it. And the data's in there, but somebody's got to go. It always gets down to God's in the details and who's going to really do the job. It's nice to talk about it, but somebody's got to do the work. This is just a rough example of what you might do as a care manager. You do collaboration, advocacy, resource, attention to quality and cost. And the biggest thing here is this, attention to quality and cost, because that's what's going to drive whether the program goes or not. I gave you a whole bunch of these. You have the sheets in front of you. I just wanted to let you know that, for instance, these three are all the same. The Patient Protected and Affordable Care Act is the Affordable Care Act is Obamacare. So you don't get confused when you're reading this in lay literature or professional literature. We talked about children's special health care needs, child health plans, CATCH, the Center for Medicare and Medicaid Services. You're going to hear a lot of that. You should know this. The person at the CMS that is going to monitor and oversee all the, what are now called primary care medical homes, is a guy by the name of Patrick Conway. I know Patrick. Patrick is from Cincinnati Children's Hospital. He was a hospitalist here for many years, and he is now the Deputy Vice President of CME for accountability and quality in medical homes. So directly, if you need to contact somebody, contact Patrick and tell him you're from Cincinnati. You'll probably get through the phone that way. Clinical quality measures we talked about. HIS is not his and hers. It's Health Information Systems. Those are your usual things. And so, in summary, we understand the medical home is, that's a typo on my part, an important topic to learn. We better understand the components. We know the barriers. We discussed your opportunities, and whether it will achieve the goal of enhanced quality of care and reduced costs remains to be seen, because it's been around for almost 50 years and it hasn't been successful yet. There's some references. You'll notice that this was October the 1st of this year. Doctors find barriers to sharing digital medical records. Those are some references for you. I'm open to any questions.
Everyone probably has a good question. Yes. Let's take it away.
Okay.
Do you think that there is an answer or a solution that could be met within, because I see it spiraling out of control. I feel like we're never going to make leeway because, Democrats can't agree with Republicans and can't make things pass. So what do you think that they should do, or how do you think it could run better?
You want my bias?
Yeah, I want bias. I want your honest opinion.
Okay. My bias is that it was a bad law to begin with. It was 2,700 pages, and nobody read it. And in my mind, that's irresponsible. You don't have a document that's important to the whole country. It's changing a whole culture. It's changing 1/6 of the gross national product. And you just pass it on a whim because you happen to be in political power. There's too many things in there that don't belong in there in the first place that aren't even related to health care. And it conflicts with itself, depending what page you're reading. So the only solution, as I see it, is they should repeal the law itself and replace it with a better law. There are good things in there, but it's going to take somebody that is really knowledgeable about the whole law and can take out the good pieces and say, this is where we should be. Now, I think the Republicans are equally as irresponsible, because that's what they should have been doing for the last 6 years. So that when they get to 2014, 16, where they might have some control of the Congress, they'll have a real plan. And they don't. But I think that's the only real solution, because otherwise I think we're like a ship without a sail or a rudder. And how you're going to monitor, and the fiasco of setting out, trying to get people to sign up for the system was a mistake in health information systems. We don't know if that's really been corrected yet. People are coming into doctors' offices today saying, yeah, I signed up, I got my insurance, and people in the offices are saying, we can't find you. They come in and they say, well, yeah, you're on my, I can tell you that the directories from the insurance companies, and this has been going on for, health insurance started in 1930, for probably 50 years at least. The directories are 2 years old of the networks. So you get your little book and you say, oh, gee, Dr. Deitschel's right on there. He's in my health plan. And you come into my office and we say, no, we haven't belonged with that health insurance plan for 3 years. But you're sick, and I'll see you. And we'll worry about the bill later. Unless you're in one of the bigger groups where you got to be all within the system, and then they're going to tell you to go to the emergency room. That's not good health care. That's no continuity of care. So I think if we can repeal it and replace it, will be the best bet. Most likely that will not happen politically. So I think what you're going to see are little pieces of, just like Hawaii took 7 years to get their thing done, where they're going to take a little piece of it and they'll replace that with what they think is better. And that's just going to take, you'll all be nurses and out working by the time that ever gets done, if it ever gets done. It's going to take some real leadership, and I don't see it right now. That's my bias. That sort of, anybody? I'd be happy to debate it with you. That's okay with me. I have no axe to grind. My day, I'm emeritus now. I just